9:15 I have another small meet. So
Pannisalam sir.
Panni, we are muted.
In between phone call. So now I'm going to cut it.
Sir, Panni sir, Balaji here, sir.
Please.
Yeah, sir, Dr. Rajesh sir, he got infected. He got hospitalized, so he cannot able to join.
Oh, sorry.
And Dr. Manigandan sir will join in 5 to 10 minutes, sir.
Right.
I joined.
Good
evening, sir. Good evening.
Yeah, sir. Sir, good evening, Manigandan sir.
Right.
Venkatraman sir, good evening, sir.
Good evening. Good evening.
Yes, sir. Sir, we'll start the meeting, sir. I'll ask Viraj, you can open for delegates now.
Okay, sir. Okay, sir. I'm making live now. Yes, sir. We are live now, Balaji, sir.
Thank you, Viraj. Shall we start, sir?
Please.
Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I'm Balaji. Take great pleasure in welcoming all the eminent doctors for today's panel discussion. Doctor, today's panel discussion will be titled Views on Vildagliptin, wherein Vildagliptin experiences will be shared by all our eminent panelists and moderator. To have this today, Doctor, we have Dr. Pannisalam sir as a moderator, who will be taking us for the entire panel. So we have with us eminent panelists who will be contributing for the said topic. At Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. So, sir, I'll give a short introduction about our moderator and panelists. Let me first welcome Dr. Pannisalam sir. Welcome, sir. Dr. Pannisalam sir is a known faculty for all the doctors for entire Tamil Nadu. Doctor is a senior consultant diabetologist who is currently associated with Aruna Diabetes Center, Chennai. Doctor is a academic.
Quickly tell our names and we can proceed. All of us are repeatedly exposed to meetings.
And let me take this opportunity to welcome all the panelists. Firstly, I'd like to welcome Dr. Sridhar sir. Sridhar sir is a senior consultant endocrinologist who is currently associated with the Miyod Hospital, Chennai. Welcome, sir.
Welcome.
And we have with us today Dr. Vamsi Mohan sir. Vamsi Mohan sir is a senior consultant physician and diabetologist who is practicing at SP Hospital and Orthomed Hospital, Chennai. Welcome, sir. And we have with us today Dr. Venkatramanan sir, who is a consultant nephrologist who is practicing at Vellore. He is currently associated with KVR Medical Center at Vellore. Welcome, Venkatramanan sir. And we have with us next panelist Dr. Manigandan sir. Dr. Manigandan sir is a consultant physician and diabetologist who is practicing at Vellore. Doctor is currently associated with the Thirumal Hospital, Vellore. Welcome, Manigandan sir.
Dr. Rajesh from Kodambagama.
Yes, sir, Dr. R.P. Rajesh sir.
Oh.
He could not able to join because of the emergency, sir.
Oh, emergency only. But he is well, isn't so? He is all right. Right.
Yes. So with this short introduction, I will hand over the session to our moderator, Pannisalam sir. Sir, you can take it forward, sir. You can set the context for the webinar.
Right. Shall we go for share screening and open the questionnaire you have sent? Or you are going to show those questionnaires, 5 questions you have sent?
Yes, sir. I'll try it from my end, sir.
From here also I can operate it.
Yes. Yeah, Viraj, you can make Dr. Pannisalam sir as the host so the doctor can present.
So there are about 5 questions that we will discuss.
Yes, sir.
5 or 6. So how many audience will be there roughly?
Yeah, sir, there is a separate link, sir. I'll just update you, sir.
Right.
Yeah, Viraj, you can confirm once Dr. Sir, Pannichulam sir as a host. Sir, you can start with the first point of discussion. I will present from here, sir.
Right. You can present from there also.
Sir, just taking time, sir. You can discuss with the first point, sir. Yes, sir. Yeah, you can present now, sir.
Shall I open my PowerPoint or?
Yes, sir. You can share now, sir.
Right.
The co-host now.
Right. Then you might have told me earlier. Is it visible, sir?
Yes, sir. Yes, sir. We can able to see the screen.
Yes, sir. Visible.
Right. This you might have told us earlier. Right. No problem. So I welcome my colleague Dr. Sridhar sir and Vamsi Mohan, Venkatramanan and Manikandan. Both are from Vellore. And of course, Rajesh is not in a position to join. And welcome person like Viraj and Balaji. They have taken some effort to share vildagliptin. Of course, vildagliptin is for many of us, I think more than 15 years molecule. It got introduced in 2007. So now almost 14 years over. Otherwise, we have rich experience with vildagliptin. And our senior colleague also will know at the time of introduction, we are not that much oriented towards GLP and GIP because GLP and GIP, there are few lines in the biochemistry textbook and physiology textbook. So the mechanism of action, the beneficial action of all those things were unaware during our UG, PG as well as diabetology course. And while we went for meeting also like IDF, EASD, ADA, some posters will be there during 2003 and 2004. We will be repeatedly reading because our mind is tuned to sulfuria, stimulate the beta cell, releases the insulin, control diabetes. Insulin straight away metabolizes the glucose and gives us the energy, controls the diabetes. Metformin to a certain extent clears the insulin resistance. This is the mechanism we had understood from 1923 to 2002 or 2003. But this so-called DP4 inhibition on top of GLP elevation and GIP, they help the beta cell and controlling diabetes. This mechanism was earlier difficult to understand. Now, incretin-based therapy is a separate topic, like your insulin-based therapy, sulfuria-based therapy, incretin-based therapy. So, incretin, we have endogenous incretin, that is GLP-1 and GIP. And exogenous in the form of parenteral also GLP-1 receptor are. And now the combination of GIP and GLP also going to come, and combination of GLP plus insulin, basal insulin also there. So there are a lot of developments within this 10 or 15 years in this area. Otherwise, this gliptin-based therapy or incretin-based therapy is advancing globally. So that only the sulfuria-based therapy is coming down. So sulfuria, all of us know, it was used liberally for so many years, 50, 60 years, but it causes hyperglycemia, weight gain, and the CV risk. So we have to minimize the use of sulfuria. So to the small introduction, so we are going to discuss elaborately for this 1 hour about vildagliptin. So vildagliptin and verify trial. So to start with, I will go with our senior person, Dr. Sridhar sir, what the Verify trial says, sir. Given the progressive nature of newly diagnosed type 2 diabetes, how do you view combination therapy as a strategy in optimization of early diabetes management in the background of Verify trial?
Yeah. Good evening, Dr. Paneerselvam. Good
Thank you,
evening
sir.
to all colleagues. I thank Alchem for this nice opportunity. And as you said very rightly, all of us are now quite well experienced over more than a decade with the vildagliptin. So to answer your question, now as told earlier, the UKPDS was one of the landmark trials in type 2 diabetes. And what was special about that was it enrolled patients with new onset diabetes. In other words, patients were picked up early in the course of the disease, and they were confined to two groups, that is intensive management and regular conventional management. And there was a difference of only 1% in HbA1c, and still it showed so much improvement in microvascular complications and mortality, cardiovascular mortality, etc. And then they followed up with the EDIC trial and demonstrated the legacy effect. Whereas there were other trials like the Accord trial, the VADT, and etc. They picked up cases much 10 years later, a period of poor control. And in fact, the Accord trial, there was increased mortality, whereas in the VADT trials, etc., there was no big improvement. In fact, what they tried to do was trying to lock the stable after the horse has bolted. So what I'm trying to say is we have to hit early, hit hard, and start combination therapy early. And so this was extremely well demonstrated in this verified trial, where when the HbA1c was 1.5% above the normal, straight away they started a combination rather than waiting serially for one by one to improve, because each drug is going to fail after some time, as showed in the UKPDS trial. They started a combination therapy with when the A1C was 1.5% higher, with a combination of vildagliptin and metformin, rather than using vildagliptin alone or metformin, increasing the dose of metformin. This combination therapy achieved the requisite HbA1c much faster, and more patients achieved the target, and the side effects were also minimal. So one of the important morals of the story was the combination therapy should be addressed without fail, rather than trying to experiment by increasing the dose of each individual drug to maximum. Rather than that, use low dose combination therapy and achieve much better results, and use two synergistic molecules.
Thank you, sir. Thank you, sir. You have very well highlighted about the combination. Once the A1C is 1.5% higher than that of the normal level, for example, 8.5 or even 9. So, of course, earlier we were using combination therapy also, metformin plus chlorpropamide, then metformin with glibenclamide, metformin with glyphosate, glycoside, and even glimepiride. These combination also helped us to control diabetes. The difference between the controlling diabetes with metformin sulfuria, metformin vildagliptin is entirely different. If you start the patient on 100 patients on metformin sulfuria, I could say definitely 30% of them will develop hypoglycemic symptom within 1 month to maximum 3 months. But here, if you start the patient on metformin plus vildagliptin, they will not develop hypoglycemia. And prolongation in control of diabetes also will be there when compared to sulfuria. In that way, as Sir told, you can confidently start the patient on, instead of lifestyle modification, metformin, not getting control, then adding your vildagliptin separately or in combination. You can straight away go for, once the control comes, then you can either downwardly titrate the dose or maintain the same dose. For example, fasting is sometimes less than 80, postprandial less than 140 or less than 120. You can downwardly titrate the dose also. Sometimes it happens in this combination also. Even if they enter into lower side, they will not face hypoglycemia. Whereas in metformin sulfuria combination, they face hypoglycemic problem. That is the major advantage. And weight gain for defensive eating, they develop a weight gain. Here, the weight gain will not be there. That is the advantage of combination. And verified trial beyond doubt proved also. We'll go to next question, sir. So the question directed by the moderator to the panelists: how do you see vildagliptin as a worthwhile add-on treatment option to metformin sulfuria and insulin SGLT inhibitor who have inadequate glycemic control? Otherwise, about EDGE study. Over to Dr. Vamsi.
Thank you, and good evening to all our panelists and the colleagues who are listening in. I think vildagliptin, now we have had more than 12 years experience of using this drug. And one of the beauties of this drug is, by itself, it doesn't cause hypoglycemia. It is weight neutral. And it's a great drug to add on to an existing treatment when the A1C goal has not been achieved by the previous agents whichever the patient has been taking. But combining with metformin, as we already saw in the verified trial, and starting as a fixed dose FDC right from the beginning, when the A1C is above 7.5, above 1.5, above a goal, we've been able to achieve good results, not only in the initial phase, but also durability of this combination is much longer than having a monotherapy and titrating the monotherapy upwards. The combination of both vildagliptin and metformin, they work in different ways. I think that's a very good combination in the sense, not only do we get a good control, but without the effects of weight gain or hypoglycemia. That's one of the advantages of this combination. And we have different doses also available, with 500 milligrams of metformin, 850, 1 gram. So we can titrate the dose even in this combination as required as the time goes on.
Recently, sustained release of vildagliptin also got introduced.
Now it has come, sustained release, and vildagliptin immediate release plus sustained release metformin. I think that combination is also available now. Yeah. Another thing is, a lot of studies have shown that vildagliptin can be combined with other oral therapies also. There are studies with glimepiride, there are studies with pioglitazone, there are a number of studies with SGLT2 inhibitors, and of course it can be used whenever insulin is also added to this to require to get the A1C under control. In most of these studies, vildagliptin has the advantage of giving a good A1C reduction of about 0.8. And if you start at a high A1C, definitely even up to 1.2 reduction in A1C can be achieved depending on the baseline A1C. In combination with SGLT2, now in vogue, we are using a lot of fixed-dose combinations available of SGLT inhibitor and the deep inhibitors. What we have seen is we reduce the burden of the tablets, and also we are able to achieve a good A1C control without hypoglycemia in this combination. And once we start this combination, the patient's requirement for SU comes down. The requirement insulin dosage may also come down subsequently, and therefore the added benefits of a lower dose, the patient really appreciates the control with a lower dose of insulin. Especially insulin, the patients are much happy to go down the dose. And we also reduce weight gain as we reduce the quantity of insulin. And also probably by using this combination, especially with insulin, we can also prevent the weight gain that occurs when we use high dose of insulin. So it's a good drug, can be used right from the beginning as a fixed dose combination, can be added on as a second drug, as a third drug. So whichever position we choose, the results are very good. And whichever background medicines the patient is taking, adding this provides a definite reduction in A1C. So I think it's a versatile drug which we have been using for the last 10 years.
Thank you, Vamsi. As Dr. Vamsi pointed out, if you are adding along with insulin, if you're adding along with the sulfuria, if you come across, definitely you should reduce or downwardly titrate or de-prescribe insulin dose as well as the sulfuria dose. Earlier, now recently they have reduced the cost. Earlier, because of its cost, including our colleagues under the impression this is more powerful drug, powerful than that of the insulin sulfuria, and they immediately stopped this medicine. That attitude should not be there. Because of this wonderful mechanism of improving the GLP-1 and GIP, whenever the blood sugar goes high, it stimulates the beta cell, releases the insulin. Whenever the blood sugar comes down, it stimulates the alpha cells and prevent the hypoglycemia by breaking down the glycogen. So once such things are happening, definitely you have to downwardly titrate sulfonylurea and insulin. As we pointed out, this drug can be combined not only with the metformin, pioglitazone, alpha-glucosidase inhibitors, and SGLT inhibitors. But only thing you have to closely monitor. And among all the group, sulfonylurea and insulin is the hypoglycemic agents. If they are there, downwardly titrate and give safe control for the patient. That is the message for all the practitioners. Because there are a lot of studies for all these things, as we pointed out. And they might have seen the studies also. If you are interested, you can go through those studies also.
And, this combination has also been approved post-transplant also.
Correct.
Post-transplant.
We'll move on to third question. How do you see vildagliptin as worthwhile add-on treatment option to metformin, sulfonylurea, metformin, insulin, SGLT in the patient, inadequate glycemic control? Of course, now we have elaborately discussed now SGLT inhibitor as well as vildagliptin combination. Otherwise, what do you call the remogliflozin, vildagliptin combination is available in the market. Your linagliptin plus empagliflozin available in the market, and your dapagliflozin, saxagliptin available in the market. So you have to understand the pharmacokinetic and pharmacodynamic of each molecule. Then you have to choose the patient accordingly. Just like metformin or alpha-glucosidase inhibitors or vitamins, we are not in a position to prescribe. So you should have some knowledge about pathophysiology behind those patients and pharmacokinetic and pharmacodynamic of these molecules and side effect profile also. With this background, definitely you can choose these combination. For example, your vildagliptin plus SGLT inhibitor is a good combination. Weight neutral, patient will not develop hypoglycemia. Similarly, metformin plus alpha-glucosidase inhibitors also a good combination. They will not cause hypoglycemia. In such a way, you can select the combination. So whenever you select the combination, as we have told you earlier, sulfonylurea and insulin is there, you downwardly titrate it, and you will have smooth control. The combination of SGLT inhibitor, DPP4 has potential to produce a robust reduction in the A1C. This combination is particularly appealing in light recent findings of glucosuria produced by the SGLT inhibitor and increase in the rate of your endogenous glucose production or hepatic glucose output, which offsets the glucose lowering effect of the approximately 50% as DPP4 inhibitor inhibit the glucagon secretion and reduce EGP whenever the blood sugar goes high. One can speculate the combination of DPP4 SGLT inhibitor would prevent the increase in endogenous glucose production. Endogenous glucose is neoglucogenesis otherwise. SGLT inhibition and produce additive, even synergistic effect on the HbA1c. So SGLT inhibitor simply throws away the glucose whenever the renal threshold crosses from the renal tubule. DPP4 inhibitor improves the beta cell function by increasing GLP-1 and GIP. So by this mechanism, the blood sugar is beautifully getting controlled. We'll move on to fourth question. How do you see vildagliptin as a worthwhile add-on treatment option? So again, metformin, sulfonylurea, insulin, the same thing is getting continued. Dr. Manikandan can add some more points on this or your own experience.
Actually, as thank you, sir. Thank you for everyone, panelists, on the moderator for offering me this opportunity. Actually, as Sridhar sir has already explained, the vildagliptin with or without metformin is an effective therapy in reducing the HbA1c, helps in achieving the target glycemic control in well-tolerated Indian patients with type 2 diabetes quantum. Actually, as sir already told about the verified trial, we have seen that the initial combination therapy with the vildagliptin with metformin was able to delay the treatment failure for almost by 3 years when compared to the initial metformin monotherapy. The initial treatment failure was seen within 3 years of starting metformin alone, whereas on the patients who have started with vildagliptin with metformin combination, they had treatment failure only. First primary treatment failure was only seen after 6 years, about 60 to 65 months, which is a significant period which the patient can benefit when you start as an initial combination therapy with vildagliptin. And also, if you see that the vildagliptin as an add-on to sulfonylurea therapy, it showed a better glycemic response and without any low risk of hypoglycemia when sulfonylurea was added to the vildagliptin. And the caution should be taken that when you are adding a vildagliptin with the sulfonylurea, the dose of the sulfonylurea should be reduced. And there are in a patients, type 2 diabetic patients, Indian patients, whom there is not proper response with the, if you're not able to achieve the target HbA1c level with the metformin and the sulfonylurea, a vildagliptin can be a better option or a third option rather than directly go and starting on an insulin, because it is weight neutral and also it has synergistic effects with the metformin and sulfonylurea.
Very good, very good, very good. You have very well highlighted. Yes, these three combinations. Earlier, as you have correctly told, that Sridhar sir, Vamsi, myself and all, once metformin, sulfonylurea are not controlling, no other way, we had to go for insulin. Third option, only insulin was available up to 2000. After 2000 only, we started receiving alpha glucosidase inhibitors, TZD, gliptins, gliflozins, etc., etc. So till then, if maximum dose of sulfonylurea, for example, dianyl 5 mg PDS, metformin 500 mg PDS, not controlling, 30% of the type 2 diabetes will not come under control. We add insulin, mixed out 40 units in the morning, 40 units in the night. Despite adding insulin, 10 to 20% will not come under control. This was the problem we had, because the pathophysiology, available drugs, understanding earlier, these are all entirely different 20 years before. Now the understanding, pathophysiology understanding and available drugs and sharing the knowledge, despite COVID, now also they are sharing the knowledge. They are all enormous. So ultimately it should get translated towards the patient care. So we should maintain the good control. So the idea is in future we have to reduce drastically the complications of diabetes, like reducing the complications of leprosy. We have to reduce the complications of diabetes. So we'll move on to another question. Type 2 diabetic patient with reduced renal function, adequate glycemic control is essential to delay progress of kidney dysfunction, but they are at great risk of experiencing hypoglycemic events, especially with the longer-acting sulfonylureas. How would you assess the role of vildagliptin in CKD? See, especially with the longer-acting sulfonylurea, I would like to share some practical experience I had during the 90s. One of my diabetic patients, or one of the patients I received in Diabetes Hospital where I was working in Diabetes IMCU during the 90s. He is known diabetic for 7 years, was on dianyl 1-BD, metformin 1-BD. Then subsequently developed CKD, diabetic kidney disease. Then started developing low sugar. The attended doctor reduced the sulfonylurea dose and even metformin dose also. But patient is going in for recurrent hypoglycemia. He got admitted in the IMCU. For 2 or 3 days, whenever the blood sugar we do, 45, 65, despite 5% dextrose, 10% dextrose, his blood sugar persistently low. Then only we came to know, which better understanding, the insufficient secretion of insulin from the beta cell 5-6 years before at the time of development of diabetes. Now, endogenous insulin also getting excreted or metabolized through kidney. Once the kidney develops nephropathy, the endogenous insulin, which was insufficient earlier, will become more sufficient, or the degradation is getting slowed. So that only they are going for recurrent hypoglycemia, even without any drug also. I could say 1 or 2% of all our diabetic kidney patients are all facing this problem. So the mechanism is, earlier we were trying to control short-acting insulin or sulfonylurea for the people who develop DKD, or sulfonylurea, especially glycoside. Now, after introduction of gliptin, so-called hypoglycemia is not there. Whenever they enter into less than 60, they go for our glucagon started secreting, the hypoglycemia is prevented. Otherwise, after introduction of linagliptin or enagliptin, so the hypoglycemia is getting prevented. Such episodes are also, otherwise downward titration of the dose, even in presence of gliptin also is essential. To throw more light, our nephrologist from Vellore, Dr. Venkatramanan, I think you participated in failure meeting also, one of our meetings, isn't so?
Yes, sir.
Right. Over to you, Venkatramanan.
Sir, good evening, sir. Good evening, Pani sir, Vanshi sir, and Sridhar sir, and my colleague Manikandan. I think you people are also better experienced with the CKD people. And the CKD up to 60 GFR, less than 60 won't be much problem because most of the drugs we can use. But once the problem happens in the CKD stage 4 and the stage 5, even in stage 3 also, we can use most of the drugs. But once it comes to the stage 4, we are a little bit reluctant to use even metformin nowadays. They are telling even we can use up to GF. If the patient is stable and there is no any risk factor, we can use up to GFR 30. But we can't introduce the new drug if the GFR is less than 45. And regarding the sulfonylureas, we are using mostly that is glyclazide, or even in the glipizide in the GFR, that is the CKD stage 4. But coming to the gliptins, I think most gliptins we can use, but we should be very cautious because gliptin is not a nephrotoxic drug, and mainly it can cause, when the dose is high, it can cause transaminases, mainly liver dysfunction. So the gliptins, sitagliptin we are using, and vildagliptin we are using, even we are using linagliptin, and even we are using teneligliptin. But important thing is the dose modification, because only 50 milligram OD, the vildagliptin is enough. We are using in the CKD stage 4 and stage 5. There is, as I have told, there are some studies in dialysis patient also, some post-transplant patient also, we are using vildagliptin. But sitagliptin also using, but nowadays because of the vildas, financially it comes down the rate. We are ready to use for all the people. Previously we have only teneligliptin, but we don't have a lot of studies with the teneligliptin. But now vilda, we have comparatively better study with the vilda, so we can use better in the CKD stage 4 also with the reduced dose. The important thing, we want to use dose modification, nothing else. But even the SGLT also we can't use if the GFR is less than 30. So the only choice available is the gliptins, or that is the insulin, or sometimes we can use glyclazide with a little bit cautious. This is about the mainly what we are using, especially in the dialysis patient. Dialysis patient, normally they may need 4 units or 3 units of the insulin to maintain the euglycemic state, but sometimes it may be painful with for 4 units. Other time we will be comfortable with the gliptins, or even Lina is a little bit costly, so we are comfortable now with the Sita or vildagliptin with 25 milligram or 50 milligram, so that they are maintaining euglycemic and there's no need for insulin. This is regarding our experience regarding the gliptins of the CKD patients.
Thank you, Dr. Venkatramanan. So, as you correctly told, any gliptin can be used. As we told earlier, teneligliptin was cheaper. Now vildagliptin is made cheaper, and other gliptin also going to be much cheaper because the patency is going to last within few months or few years for some of the gliptins. And my preference, Dr. Venkatramanan, earlier only no other go, because we also had a similar experience. Once we discharge our CKD patients, diabetic kidney disease patients, small dose of insulin, short-acting insulin, morning 5 units, night 5 units. Because the short-acting will act as long-acting for all diabetic kidney patients. So you should not give long-acting. If you give long-acting, they will go for persistent prolonged hypoglycemia because it will not get cleared quickly from the kidney. Even if you give glycoside or even glycoside, elimination of the sulfuria from the DKD patients, again getting very much slowed. Once they enter into hypo, they don't take food properly because of uremia, acidemia, so nausea, vomiting. They enter into severe hypo, prolonged hypo, especially in rural area, or the facility are not available. Sometimes they die due to hypoglycemia. Now we have 108 ambulance. All 108 ambulance are having meters. They recognize hypoglycemia on the spot. They start IV fluid. Before they come to the hospital, they are recovering. They are asking their ambulance attendants to go back to their village. To that level, the hypoglycemia is nowadays getting corrected. But unfortunately, 20-25 years before, we had come across a lot of hypoglycemic death because of DKD. So I personally feel, let us, even though the coding your National Kidney Foundation says that the glycoside and glycoside still they are adding, but we should come away from that. No more sulfuria for our DKD patients. So
it's based, even in dialysis also, it's based on residual renal function. Sir. Some patient, even with the CKD stage 5, they can pour good amount of urine. If they have pour good amount of urine, they can tolerate with the glycoside. But if there is urine is very nil, for example, only 100 ml.
Even for glycoside also, the problem is once they don't take food or the elimination is delayed, there are 100% chances to enter into hypo. But if they are on
normally we give only that is glycoside.
Earlier we didn't have alternate. we were now in diabetes practice also, we tell our colleagues, reduce sulfonylurea dose, reduce insulin dose. So after DKD, we didn't have earlier alternate. We had short-acting insulin and short-acting sulfonylurea, and glycoside also still safe sulfonylurea, no doubt. But definitely, sulfonylurea is sulfonylurea only. At one particular point of time, it will cause hypoglycemia. But whereas if the patient is on linagliptin or vildagliptin, patient will not face hypoglycemia. That confidence we will have. So better the guideline also they should be like this only we have repeatedly told the ADA people. ADA in 2018 only removed sulfonylurea as second line drug. Till then ADA was also maintaining sulfonylurea after metformin. Now 2018, 2019, 2020 content, sulfonylurea have gone to backbench now. Right?
Definitely.
Because of this, still some other practitioners are prescribing glycoside for DKD patients. We do come across hyperglycemia in such patients. While we have better molecule or better understanding about gliptins, why should we not use this?
Definitely.
Right.
Now, previously the cost was the issue. Now it's not an issue.
Yeah, it's not an issue. It's not an issue, and we have rich experience also. See, gliptins are earlier pancreatitis, pancreatic tumor, and skin infection, pemphigus, and sometimes joint pain. These are all some noises they made a few years before. Now the information is globally shared, no such complications or no such adverse effect. You can confidently use gliptins. We'll move on to the next question. So management of type 2 diabetes is in elderly patient is complicated by high prevalence of CV risk factors, other comorbidities, and high risk hypoglycemia. So we, like CKD patients, we do come across elderly patients. How do you see the role of vildagliptin in the management of type 2 diabetes in elderly patients? I request our senior colleague, Dr. Sridhar Sir, to throw light on his own experience also.
Yeah. First, we should, there's one slide which is on precision diabetes, which I think one of the best slides I've ever seen, in which they look at the age of the individual and also the age of the disease, etc., his comorbidities, his renal status, his hepatic status, etc. So here, our focus is not an extremely tight blood sugar control. Rather, the focus is avoidance of hypoglycemia. This is the primary focus, and improving the quality of life for the patient. So if the metformin is not sufficient, or if metformin alone may not be good, or even without metformin, two drugs which come into the picture are one, the gliptins, and the SGLT2 inhibitors for least hypoglycemia. But the SGLT2 inhibitors in old age is not a good choice. Yes. Mainly because the problem of osmotic diuresis, effect on blood pressure lowering effect. So I would be very hesitant to start an SGLT2 inhibitor in the old age. And sulfonylureas are also not that preferable, mainly as you discussed, the problem of hypoglycemia. So unless unavoidable, it's better to also avoid sulfonylurea. And the TZDs have low chance of hypoglycemia, but they have the other problems like cannot be used in type 3, stage 3 and 4 of New York Heart Association, cardiac failure, the problem of edema, etc. And most adults at that age have some evidence of cardiac failure. So that is also not a good choice. So eliminating all these things, so now the gliptins as a whole are probably the drugs of choice in the elderly. And out of which vildagliptin I've used in many patients, more than maybe 1,000 patients of elderly patients, and most of them seem to be doing extremely well in the drug. Just the single dose, 50 mg OD, is doing wonders and achieving the control. So because of this low potential for hypoglycemia, because of its patient-friendly nature, and also it's even in CKD, as it was discussed, less than 60 ml creatinine clearance is most of the elderly may be there. So in that situation, 50 mg OD of vildagliptin is what is indicated, and that's what's mostly given. In other words, vildagliptin is the drug of choice for the elderly in diabetes mellitus.
Thank you, sir. Thank you, sir. Thank you. Because as we repeatedly discussed, earlier we were not having safe molecule. We had control. We have controlled. But unfortunately, those two molecules were causing hypoglycemia. Now we can, as sir pointed out, confidently use gliptin and hypoglycemia risk, weight gain risk. While SGLT inhibitor is there, as he correctly told, electrolyte imbalance, hypotension, UTI, these are all the other problems with the SGLT inhibitor. So by keeping all those things in the mind, you can prescribe SGLT inhibitor. Otherwise, vildagliptin plus metformin or vildagliptin alone will help the elderly safely without hypoglycemia, and the food control can be achieved. Thank you, sir. So next question, how do you see vildagliptin versus other gliptins? My colleague Vamsi, because he also has rich experience with other gliptins.
Now, see, this is a tricky thing because
yes,
we
all are banana. Which banana you want to prefer?
yeah. As far as the A1C reduction is concerned, I think most of the gliptins are more or less equal. So you start at a high base A1C, they do very well. You combine it with metformin, they do very well. So most of the, as far as the glycemic control is concerned, vildagliptin or any other gliptin are more or less similar. And also, if you look at hypoglycemia events, more or less similar. And all of them are weight neutral. The only difference might come if you're looking at the CVOT outcomes, basically. So that is one. And we have seen that all the other gliptins have had a dedicated CVOT except vildagliptin. And one of the reasons why was they said they had enough material in phase 3 and phase 4 studies to give a conclusive evidence that vildagliptin is neutral as far as CV events are concerned. So that is the answer. But we have seen that in the VIVID trial, where patients with class 1 to class 3 NYHA heart failure were studied with the addition of vildagliptin to their backbone therapy to see the effects. And they found that it did not increase CV events. But on the other hand, the overall mortality, all-cause mortality, was slightly higher with vildagliptin compared to the placebo arm. And also, there was a change in the end systolic and diastolic pressures in the heart, even though further studies will have revealed what this could have meant. But we have no idea where this proceeded after that, because I don't think there's any follow-up of these patients after the trial was over. But we will assume if the end diastolic and systolic pressures are going to increase, whether it can lead to deterioration of the cardiac failure. In the VIVID trial, there was a 3 to 4% increase in the ejection fraction in the vildagliptin arm, but statistically it was not significant compared to the placebo arm. So we don't know what could have happened if the patients were followed up for another few years, whether this could have resulted in any other changes in the cardiovascular outcomes. We've already seen the safety if the dose is corrected accordingly in the people with CKD. So we established its usefulness in CKD because of its good A1C control without the dreaded effect of hypoglycemia. The other gliptin, which had a problem with cardiovascular, especially the heart failure, was sitagliptin, and in some cases allogliptin. Both of these had a marking for increased admissions for heart failure, even though the subsequent analysis was blamed on the selection of patients towards the end of the trial, which events were increased because of addition of more comorbid conditions. So the patients who had a high risk were also included in the study. That's one of the explanations for saxagliptin showing probably a higher admissions for heart failure. So as far as heart failure or CV events are concerned, vildagliptin has proved itself to be as safe as other gliptins. So the only question mark would be whether these changes in the end-systolic and diastolic ventricular pressures or a change in the all-cause mortality, was it significant if the trial moved on from there? So I think this shows that it is as good as the other gliptins as far as glycemic control is concerned. As far as other gliptins, no hypoglycemia, no weight gain, CVOT. From the evidence we have, I think it is safe to continue, except probably in patients who are already having maybe a class 3 beyond heart failure, and probably we don't be using any gliptin in that
Yes.
class of patients anyway.
Of course, saxagliptin is the only worrying. Saxagliptin and erogliptin. Remaining gliptins, including vildagliptin, sitagliptin, and linagliptin, they prove to be safer in cardiac. Of course, in gross failure, but gliptins are not going to be helpful. There's some amount of adding SGLT inhibitors, then not getting controlled small dose of insulin will help such patients. Thank you, Vamsi. We'll move on to last question. So with the evidence of base gliptin gone off patent, the generic variants have flooded the market, resulting in sharp drop in price. How do you view the expanded role of an economical and evidence-based vildagliptin in spectrum of type 2 diabetes? This is for Manikandan, because you are practicing in the official. In city also, sometimes the middle class, below middle class people grumble about the cost of therapy. After reducing the cost or after the patency had gone, obviously your experience, how the patients are feeling, how much useful this molecule of reducing the cost.
Actually, yeah, thank you, sir. Actually, after this drug patents expiry, actually I work in a very remote area in Ranipet, Mission Hospital, Tirumalai Mission Hospital under Shishadri, sir. Actually, what we have is we have a very number of patients who are coming from a very low socioeconomic status. Initially, when we had this, because initially what I'm saying is there are many patients whom were not even affordable for glimepiride. So we used to give only glipendiol or glibenclamide because that has more potency, and it has a very, I know, even though it has more propensity to cause hypoglycemia, because of many patients are very not out of, we used to use that. And when we used to give metformin, and that is the maximum thing, and then we have no other choice, we have to go to insulin, or we tend to use pioglitazone. But even though in considering many of the population have risk of osteoporosis and the weight gain is there, we have no other choice, so we used to give pioglitazone. And then we had, once this patency of the vildagliptin was over, initially we had this teneligliptin because it was around 15 rupees or 15 rupees per tablet. And once this combination, this vildagliptin patency has lost, we could use for almost many of our patients the benefit by using this vildagliptin after the losing patency. So we can even give twice daily, which initially used to cost around 15,000 per month. Now it has significantly reduced to 5,000 per month because of this combination. So it is very useful for us, especially in the remote areas.
Thank you. Here also, in our experience also, the deserving population now freely getting gliptin. Earlier, for deserving population, we cautiously write. Once we prescribe, they are supposed to buy. If they don't buy, then what is the point in prescribing? So earlier we have to search for the people who will continue to take the medicine. Now, hardly less than 10 rupees, almost all companies. Sometimes I used to jovially tell our patients, the tea cost about, or the coffee cost about 15 rupees, even the small stall. So if they take 2 or 3 teas per day, equal to that cost only. So now otherwise the gliptin therapy is cheaper than that of the tea or coffee cost now. So better make use of the gliptins for our patients. Sir, Dr. Vamsi and Dr. Sridhar sir permits, I will show 2 cases, sir, how the gliptins are helping.
Yeah, please go ahead, sir.
Yes, sir. Thank you, sir. So this patient was on glimepiride. Usha, 2006, he developed diabetes. I saw only in 2009. Her A1C 2007 was 10.8.
Screen was not visible, sir.
Oh, sorry.
Yeah, you didn't share your slides.
I think I have shared it. 1 minute. Now is it visible?
Yes, sir. Now it is visible, sir.
So this patient, Usha, 2006, she developed diabetes. I saw only in 2009. Her A1C in 2007 was 10.9. And after GTT, it went up to 398. She was prescribed glyphosate G2, one in the morning, one in the night. Metformin 500 milligram, glimepiride 2 milligram. So totally 4 milligram of glimepiride. Reduced the dose HbA1c as 7.9. See the gross glycemic variability: 169, 232, 129, 269, 199. A1c came down from 10.9 2007, 2009 7.9. But after coming here in January 2009, almost now 12 years she is on follow-up, we reduced the dose of glimepiride as one dose. Night dose we stopped. Glyphosate and voglibose. January 2009, March 2009, 92, 138. We further reduced the glimepiride dose. Metformin night, voglibose. Then 139, A1C 6.9. We stopped the glimepiride totally. Vildagliptin, metformin, voglibose only from 2009. Almost now 11 years, 115, 6.7, 150, good. 7.3, 7.7, 6.8, and 6.7, 6.7. So vildagliptin, metformin, voglibose combination. 7.1, 6.5, 6.5. So 10.9 was the A1C in 2007. Sulfuria 4 milligram stopped. Metformin, voglibose from 2009. No insulin from the beginning. Recently we have added, because of our poor control and slight weight gain, I added hemoglobin also. Otherwise, without sulfuria, without insulin, so no point in allowing the disease to get progressed. So persistently less than 6.5 or less than 7 always. Otherwise, it is possible to maintain blood sugar without hypoglycemia or by not using sulfonylurea and insulin. Another one patient, so these are all chronic patient. 1 minute. This is the last case. She was on 35 units of insulin 2 times. Janaka, 34 year of birth, 89, she developed diabetes. I saw only in 2009. She was labeled as insulin requiring type 2 diabetes, 35 units we start morning and 35 units night, then no OHA. Because some of our colleagues say, so there is no beta cell function, we are replacing the beta cell function by giving insulin. OHA are not going to play any role. But if you add metformin and voglibose, January 2009 with the same dose of insulin, 127, 233, February, then next February 138, then 191. Next January 2010, 95, 96, we reduced the insulin dose and stopped insulin dose. Now for the past 10 years, 142, 147, 7, vildagliptin, metformin, voglibose, 7, vildagliptin, metformin, voglibose, 6.2. Otherwise, the so-called insulin requiring type 2 diabetes from 89, age now 85 years now, we were able to maintain A1C at 6.2, 6.4. Only this thing, sulfuria is there, only we have to worry. See, in COVID season, she was started taking fruits because she wants to prevent COVID by increasing vitamin C. So again, the A1C goes to 7.4. Earlier, the A1C was 6.1. Otherwise, vildagliptin, metformin, voglibose, beautifully maintaining the A1C. From 12, it is coming down to maintaining 6.5. Age is 34 year of birth, 2005 premix insulin. Insulin requiring type 2 diabetes, becoming insulin independent type 2 diabetes. Otherwise, after the arrival of gliptins and the modern understanding, modern trials, we have the confidence in stopping insulin, we have the confidence in not using the sulfuria and maintaining the A1C. Thank you, sir. Any comment from audience side or from our panel colleague side, we can discuss for some time before we end, sir.
Just one query which has come regarding once daily dosage of vildagliptin.
Once daily dose of vildagliptin, Dr. Vamsi.
Once daily, there are two things we need to know about vildagliptin in the original form. I'm not talking about the old forms now, which are new. So if you look at the introduction, it was 50 milligrams twice a day was the advised dose, because the single dose of vildagliptin 50 milligrams did not have a long half-life. So we needed the second dose in the evening to keep the DPP4 inhibition at least above 80% at the end of 24 hours. By using one drug, the level of DPP4 inhibition decreases towards the evening, and overnight there is no inhibition of DPP4, and therefore there can be a surge in the sugars. So that was the original contention why it is given twice a day, because of its shorter half-life and the need to keep the DPP4 inhibition over 24 hours. I think now with the change in technology, we're getting a lot of what are called laser technology, where there's slow dissolution of the molecule for 24 hours. Probably 100 milligrams as an OD drug can be tried with the introduction of these new forms of vildagliptin.
Yes.
And definitely that will help the patient, because when we reduce the number of pills, the patient takes it much longer. The adherence is much better. The only thing we need to see is whether the PK/PD profiles are similar to BID dosing.
Yes.
And whether this OD preparation will have a similar inhibition like a OD, like sitagliptin, complex sitagliptin. A single dose gives nearly 90% towards the end of 24 hours DPP4 inhibition. Whether we get similar results with OD vildagliptin has to be proved.
Correct. So for that purpose only, now we have self-monitoring, and you can ask the patient to take pre-dinner and post-dinner also. By taking single dose of 100 milligrams of vildagliptin, the effect is there. The post-dinner blood sugar also must be normal. So now this is all possible now because of meter, availability of meter, and you can ask the patient to monitor all the 3 times.
See, this was originally tried by the innovators, Novartis, but probably did not have that extended release technology at the time. And they said that giving this as a single drug caused dose dumping, and probably some toxicity in the liver was observed. So they had to change back to 50 milligrams twice a day at that time.
And 50 milligram BD also not that much inconvenient dose. See, invariably they miss the afternoon dose. Morning and night dose they invariably. If you are comfortable, if your patients are comfortable for single dose, you can go for single dose also. Only thing we have to monitor the blood sugar all the 3 times. Any other query, Balaji?
Yes, sir. That was the only question, sir.
Oh,
So good.
we have discussed very well about vildagliptin, sir. Of course, for us, especially panelists, it's a repeated information, and I used to tell like this: the teacher should keep on telling the same thing. Of course, the audience only will be different, or the students will be only the different. So, anything to add, sir, Sridhar sir, and Vamsi, Manikandan, Venkatramanan?
Fine, I think we did had an honest and fruitful discussion.
Yes, sir, for 1 hour.
Yes.
For 1 hour. So my sincere thanks to Malcolm and my co-panelists, Dr. Sridhar sir, Vamsi, Manikandan, and Venkatramanan, and Balaji and Viraj, and all our colleagues who attended this webinar. I think this will be useful for them clinically to have better practice. I think we can find up Mr. Balaji.
Thank you, sir. Thank you, sir. Sir, before giving the closing remarks, sir, I'd like to present just a couple of slides regarding the update on once daily formulation of our brand.
Right.
And yeah, I'll just share the screen, sir. Yeah, sir, can you able to see the slide, sir?
Yeah, go ahead.
Yeah, thanks, sir. Sir, as Vamsi sir was pointing out, like Indian companies, in fact, sir, we are the pioneers in pharmaceutical, in terms of sustained release formulations. So we are the first one to bring Metformin sustained release formulation in Indian market. Later, it was accepted globally. So similarly, Gluvilda OD, there are we had manufactured with our Gluvilda OD, we manufactured with Matrix technology. In fact, once patency got over last year, company started working on this formulation, this technology, and we did a 3 months trial wherein glycemic control was similar compared with the parent company, sir. So here we compared the DPP4 inhibition, and the graph it is clearly visible. Compared with parent company BD dosage, vildagliptin OD, Gluvilda OD, DPP4 inhibition is almost similar, which ensures like same glycemic control just like parent company 50 mg BD dosage. And also we have compared the bioequivalency study, wherein bioequivalency study has shown a similar, it is equivalent to bioequivalent to international brand. So which clearly says like Gluvildamviews OD is again, it is matching up with the international brand and giving a similar efficacy, sir. So I request doctors, panelists and delegates to give a try on Gluvildamviews OD, which is also cost effective because Gluvildamviews OD 100 mg is priced at only 10 rupees to the patient. And our plain 50 mg is priced at 5 rupees to the patient, which is most economical in the market. So with this, sir, I'll go to the next couple of presentations on Connect to Clinic, because this platform, this is a telemedicine platform, which will be more helpful for doctors during these challenging times. Just couple of slides on the latest features on Connect to Clinic, which will be more helpful for doctors who are attending this webinar. So Connect to Clinic, it is a unique platform, which is very simple and secure, reliable platform, which is available for doctors during these challenging times. So these are the new features which has been there for Connect to Clinic, which will be more helpful for doctors. So credential-based login, it is a unique login for doctors. No OTP-based login. So doctors can set their own password now. So easily doctors can get into the Connect to Clinic platform now. And patient details which can be uploaded, it is made easy now. So all the patient details can be uploaded at one go. And under My Patient column, doctor can view the details of his previous history of all the patients. And prescription can be shared. Both e-prescription as well as manual prescription can be uploaded. Now, prescription can be easily shared through email as well as SMS, along with the usual telemedicine, as well as provision of adding alternate numbers by doctors. Doctors, if they are having additional numbers or assistant numbers, can be added along with the Connect to Clinic, so that even assistants can access the platform and they can make it ready for doctor, so that doctor can immediately connect with the Connect to Clinic with the patients. An instant consultation, if there is any emergency consultation which is needed for the patient, there is an option for instant consultation, which immediately doctor can send it to a patient. So with that link, patient can immediately they can pay the consultation and immediately they can join with the doctor for consultation. And there is a option of 3-way consultation, because certain patients who are elderly patients who may require a caregiver also to be there with the consultation in the video consultation. So this consultation, 3-way consultation option is also available, wherein caregiver also can join the consultation through a link. And there is some medicine C2C med update, which is the latest one, wherein with this update, doctors can access to latest all the national and international journals, and doctor can access full text articles without any cost. And if there is any requirement of any article, doctor can post a query and immediately within 24 hours it will be addressed, and doctor will be getting those journals in this C2C med update. And patient education module is available, wherein patient education videos are there, which doctors can share it to the patient. And physical consultation is more easy now compared with the other thing. Connect to Clinic, so now it is very easy and more secure and reliable now. So to know more about this Connect to Clinic, so I request any doctors who want to know more about it, you can get in touch with our Alchem team. So thank you, sir.
Thank you, Balaji. Thank
this presentation, sir. I'll like to first thank Pannisalam sir for giving us this opportunity and accepting our invitation and moderating the panel discussion today. It was excellent moderation, sir. Not just moderation. In fact, you shared a couple of case studies, which will be more helpful for doctors who have participated in this meeting. I'd like to thank all the panelists, Dr. Sridhar sir, Dr. Vamsi sir, Dr. Venkatramanan sir, Manikandan sir, for sharing your clinical experience on Vildagliptin, which will be more helpful for the delegates. And also, I'd like to thank take this opportunity to thank all the doctors who have joined us for today's panel discussion. And I'm sure all the doctors who have joined will appreciate the views on Vildagliptin, which has been presented today by our panelists. Sir, at this juncture, we'd like to salute all our doctors and paramedicals who have contributed immensely for keeping us all safe. and healthy in these challenging times. Sir, we at Alkem will continue to serve doctors and patients by making our products available, especially Gluvilda, Jupiros, and Volcom. Thank you, sir. Thanks once again. Good night, sir.
Good night.